video. Invite Dr. Chitra Ramamurthy, who needs absolutely no introduction. She's going to talk on subluxated cataracts, unfortunately, because of some confusion. But anyway, they are tough cases, so we'll get to see more.
Very good afternoon to one and all of you. And I seem to have misread the topic, and I'm talking on subluxated cataracts. But anyway, it is about how we stabilize the bag. So basically, when we talk about bag stabilization, it's very important for us to estimate what is the kind of zonular weakness it is there, based on which we are going to decide on a plan of action, whether it's mild, moderate, or severe. Now that becomes something absolutely important, and what we see on the slit lamp is not at all necessarily the exact plan of action we take, because on the table you might realize that the area of zonular weakness is a lot more. Again, the way you are going to stabilize the bag depends on, one, the degree of zonulopathy. It also depends on what is the underlying pathophysiology, because if it is a trauma induced, we need not be so obsessive, because we could take a more easier approach. But if it is a pathological cause or a progressive kind of zonulopathy, we need to get more aggressive. So it's very, very important. The very basic tip is that this is a very elastic bag. So there's a pseudo-elasticity because of the zonular weakness. So first you place a highly retentive, cohesive viscoelastic, initiate the rhexis away from the area of the dialysis. Sometimes once you have initiated the rhexis, you could place capsule retractors to stabilize in that area and then go on to complete your thing. So this was a case of a loose capsular bag. You know, as I'm getting my nuclear fragment out, there is a tremulousness in the bag, and I decide that I have to keep my parameters low. My IOP is 40, but this is, now I would even keep it at 20. And so I keep my phaco probe right in the center. I ensure that my anterior chamber does not collapse at any point of time, and I keep injecting viscoelastic. But as you can see that I have somehow managed to do a sort of a supracapsular phacoemulsification, not in the bag. Now look at the bag, it's quite lax now. Would I place a CTR now? It makes sense to place a CTR, but I now fill it with viscoelastic and try to remove the cortex, because sometimes when the bag is lax and if you do not stretch it completely, you might actually catch the posterior capsule. So very gently, tangentially, I remove all the cortex, but I continue to inject viscoelastic every now and then, because sometimes, you know, when the CTR is placed, getting all the cortex is a little more trouble. So this was the way I dealt with it, and I was lucky enough, largely because there was no area of zonular weakness exactly, just a loose bag. So I was able to somehow, with injecting viscoelastic, stretching the fornices, stretching the posterior capsule, I was able to remove all the cortex, and then I go in and inject the iol. Now this is a case wherein there is again on the slit lamp I could not identify the zonular weakness, but as I start I realized that somehow that tactile stimulus is not there. And so I think I initially make it a small rhexis, but then I find that I was able to get a centered rhexis and I enlarge it, and now it's always when you're not too sure about the zonular weakness, you need not immediately slip in a CTR, but I place capsule hook which will go and hold it at the equator and give that equatorial support. And then as I was shopping, I found things were quite okay and going good. But then there is that small area of zonular weakness. I would put my another capsular hook there that pushes the vitreous back. So then with my low flow parameters, I start my phaco, but then I realized that at this point, somehow things were just not looking good, and I place my CTR into the capsular bag. Now the capsular hooks and the CTR are stabilizing the bag. So I now go on to complete my phacoemulsification. I keep my phaco probe right in the center and get all the pieces towards it in a very slow process with low flow parameters. And once the last piece is out, actually the parameters are very much brought down. But herein again, I inject the IOL now itself. There's still a lot of cortex in the bag, but the IOL is going to push the bag behind and then well away, and I'm not going to get the PC trampolining in, and then I loosen the supports, and then I remove my cortex and get out of it. So this is, I would show you, this is actually not exactly a case of subluxation, But it is how I'm going to stabilize the capsular bag is the point here. Here I make a Hoffman's pocket. There's just a coloboma, which means that the zonules are weak in that area, but in all the areas the zonules are okay, and actually these zonules are going to stay okay. So we could have taken a very conservative approach. It's the important thing here is you need to place the CTR because there could be a fluid misdirection in these kind of cases. But because it was such a soft nucleus, I have removed it with IA, and now I've placed my CTR, and I would always ensure that the eyelet of the CTR is well away from the area of zonular weakness. But then, what I think is why not I further stabilize it with Ahmed segment for the simple reason in that area of weakness the bag is not supported. There could be an asymmetric bag contracture, and thus I deal with this. Now this is a case of actually on the slit lamp there's a lot of phacodonosis, and I decide that I'm not going to be doing a phaco at all, and I'm not going to do Ahmed segments. So this is what this kind of subluxation demanded, and it was a severe pseudo exfoliative cataract. So I make a 3 o'clock and a 9 o'clock incision, and then I rarely ever do an SICS, but these are those situations where you used to use your common sense and think which is the best way to bail yourself out. So I use a vectis and I remove the entire nucleus with the bag out. Now it's a fairly small pupil here, so there's hardly any vitreous there, but I go ahead and do a shallow anterior vitrectomy. It's very important to do a good vitrectomy in these eyes because these are the situations where you can have a chronic inflammation post-op. And then through that incision, I push my iris clip lens. I've already got an incision at the 3 o'clock and the 9 o'clock. So just stabilize the optic of the lens, and just through the side port, I just push in some iris tissue through those pincers in the iris clip. Do a similar maneuver in the other eye. And this is just a pretty excellent way of going about it. Many would say you have to do a PI, but I believe if an anterior vitrectomy is well done, I would just continue to leave it at that. This was a patient who came to me rather, that he had already had a cataract surgery done and a CTR was placed in his eye, but he was having diplopia, and I found that his bag, IOL bag complex was subluxated, so I removed the entire IOL. But even as I was removing it, the IOL was out, but then he had already told me that a CTR was there. Now that is something we need to keep in mind when you get patients who have not got the primary surgery done by you. So I go back and remove the cortical segment, but along with it the CTR came. Now if the CTR had not come in at that time, and I know there's a CTR there, I should have my posterior segment surgeon remove the CTR and not leave the CTR dangling in the vitreous, and then again I use my standard iris clip lens and bail myself out of the moment. Now this was a patient who had the whole IOL bag complex into the vitreous, and in this kind of a situation you have to do a thorough vitrectomy, remove the entire optic, and then as Amar had showed, this was just a simple Yamini technique in which the surgery was completed. Thank you very much.
Dr. Chitra, one question which I would like to ask is that you somehow do not fancy using capsular hooks in the initial stages. Why is this a non-preference, I would say?
Why would I not? Capsular hooks, if the which stage? Capsular hook?
In the first case and in the
It
third
was
case.
First case was a loose bag. There was no zonular dialysis
It
at all.
showed some bit of...
no, there was no zonular dialysis right up to the end of the case.
And
it was
in the
just
third
a loose
case-
bag. All it needed was a CTR.
Okay.
Then the third case was second case I've used iris hooks. The third case was just a small area of zonular weakness wherein it was just a coloboma. I was just talking about how I was stabilizing the bag, and I used a CTR and an Ahmed segment to stabilize it in that case. But if there is a bag is lax, the first thing I would do is to use a capsular hook, because only that will stabilize right up to the equator. I would not think of using iris hooks at all.
Okay, great. And what are your indications for fixing the bag to the sclera and or explanting the whole bag? Because with the CTR there, in the...
Yes, that was a patient operated elsewhere, and he had come with a subluxated bag. So I removed the entire bag, and incidentally the CTR came along with the cortical remnant. So my message is that if there's a CTR there, Sometimes the CTR could be in the vitreous. It's important that the posterior segment surgeon removes that CTR finally.
Yeah,
Yeah, I think you're right. I mean, there is no doubt about it. But at the same time, we have access to both. You showed a posterior iris fixation, or you can even do a glued IOL. So, 100% is now. I don't think any of us have used a AC IOL for many years now. Some of you
Actually,
may never get to see it.
for that matter, when we talk of ACL, although we are not doing ACLs in our place, but I think it is not to be thrown out into the dustbin for a simple reason. Those days we were not managing the posterior segment issues well. We were leaving vitreous behind and we were not measuring the white to white. No, I have not taking names. I've seen some good surgeons putting in an ACIUL in modern day in a rare situation. So, it is the ACIUL went into disrepute
So
because
if
of the
you
primary surgery not being
if you
handled
take a
well.
vote of panelists, I'm sure none of us will put an
Even
ACIL
I wouldn't
today.
put.
So just a take-home message, yes, you can keep it like there was a time about 25 years back, you get a PCIL and you get a ACIL backup. So because sometimes you don't have ACIL sitting there or you don't have a posterior iris claw sitting there and you have a complication, then what are you going to do? But of course in today's era with what Amar has invented as a glued IOL technique, you tuck in, the haptic is phenomenal. There is no wobbling of the IOL, it remains stable, always well centered, it's not going to go down. But remember friends, always you have to tuck that IOL. Without tucking, that IOL is not going to stay there. If you just put the glue and not tuck, the lens will fall into the vitreous. So that's